Hi, I'm Dr. Matthew Davids from Dana-Farber Cancer Institute and Harvard Medical School here in Boston, also co-chair of the CLL Society Medical Advisory Board.
And I'm Bill Wierda from the MD Anderson Cancer Center. I direct the CLL program at MD Anderson.
Well, it's great to be with you, Bill, today. We saw a lot of exciting data at this year's ASH meeting in CLL. Actually, a lot of abstracts on Ibrutinib plus Venetoclax, which we have known for a long time based on work done at your center and our center and other labs that this could be a synergistic combination. And your group was really the first to put these drugs together in CLL patients in your combination study of Ibrutinib plus Venetoclax in the frontline setting. And this was updated at this year's ASH meeting by Nitin Jain. And so maybe you could start by just telling us a little bit about the study design.
Sure. So that trial was a phase 2 trial, meaning that the primary objective was to look at efficacy of the regimen. The design initially was for 3 months of Ibrutinib to debulk patients, and then to add the Venetoclax and do the Venetoclax ramp up, and to give patients 24 cycles of combined therapy. The original trial had 2 cohorts, a frontline cohort or for previously untreated patients, and a relapsed cohort, one for previously treated patients. The update that you're referring to from ASH was the frontline cohort. Originally, there were 80 patients in that cohort, and we reported the outcome. We added an additional 40. So our current trial and the update that Dr. Jain presented at ASH was at 120 previously untreated patients, and those patients had to have what we considered a high-risk feature when we opened the trial. High risk being those patients with 17p deletion, with 11q deletion, with an unmutated immunoglobulin gene, or patients over 65. And those patients were identified not necessarily because they were so high risk, but because we wanted to develop a non-chemotherapy frontline regimen for those patients. And so we've reported and published our outcomes for that trial, and the presentation at ASH this year was an update to those results.
So a large group of patients, pretty enriched for high-risk features, and you reported on these previously untreated patients at ASH now with longer follow-up. So what did you find?
So for that trial, the presentation reported undetectable MRD rate of 72% in the bone marrow as the best response rate for patients treated with that combination. So that was MRD undetectable status at any time in the response assessment period. So the original trial, as I mentioned, was 2 years of combined therapy or 24 cycles. We revised the protocol subsequently to allow an additional year for patients who were still MRD positive at the end of 24 cycles of combined therapy. This updated reported that 63% of those patients who were MRD positive at the end of 2 years and received an additional 12 cycles of combined therapy, 63% of them converted to undetectable status in the bone marrow with that additional treatment. A couple other features that we reported that, or particularly one that we didn't appreciate previously, but we're appreciating now, and I think it was because of the patient population we enrolled were high risk, and that is that we are seeing a higher undetectable MRD status among those patients who have an unmutated immunoglobulin gene versus those who have a mutated immunoglobulin gene. So in our update, we've reported that there are other trials with this combination. For example, the Captivate study, the FLAIR study, and the GLOW study. And those trials also are not necessarily selected for a high-risk population. They're all previously untreated patients, are also reporting a higher undetectable MRD status among patients who have an unmutated immunoglobulin gene, which was not anticipated, but I think it is important. And then finally, we were looking at time to MRD relapse, because patients are remaining in remission. We have very few patients whose disease has technically progressed, but an early outcome can be MRD relapse. And what we're finding is that there have been very few MRD relapses. Those patients who are relapsing with their MRD converting from undetectable to detectable tend to be those patients who it took longer to achieve an undetectable MRD state. So the slower responders are those patients who so far are more likely to have a relapse in their MRD. And then finally, the outcomes for progression-free survival and overall survival have been extremely good. And we've had very few patients who've progressed by the formal criteria we use, and very few patients who have needed subsequent therapy.
That's wonderful. I mean, it's really impressive results. It's amazing how much we've learned from this single study, and we'll continue to learn. So any final thoughts on this abstract?
No, I think it's, as you mentioned, one among several that evaluate this combination. And I think the results across those trials are very consistent. So we do seek and are happy about confirmation of our results being reported in multi-center studies and in phase 3 clinical trials. And we need more follow-up for this, this regimen and patients who've been treated with this regimen to better understand the long-term outcomes with the combination.
Wonderful. Well, thank you so much for the outstanding work and contributions to the field, and for patients, and for summarizing it so nicely here today. And we look forward to seeing future updates of this study.
Right. Thank you.